Welcome to the basics of rubber dam isolation. What you will see in this video is one method of making and placing a rubber dam. First, why do we use rubber dams? It helps us control the environment in our operating field. It prevents swallowing or aspirating foreign objects. It protects surrounding soft tissues and keeps them away from our work area. It reduces contamination, and this is especially important because of some of the materials we use, like composite resins, which are highly technique sensitive, and any contamination negatively affects the quality of our restorations. Ultimately, it leads to better dentistry. In this exercise, I'll be clamping tooth number 18 and extending the dam to the contralateral canine in order to achieve adequate reflection of the rubber dam material and provide ourselves with enough room to work. To place your first hole for tooth number 18, flip the rubber dam shiny side down and imagine or draw a 3x2 grid on the rubber dam and punch a single large hole at the left intersection. You can also take your typodont and slightly stretch the dam over it, making your teeth where you'll need the holes. This method works particularly well when you have a partially edentulous patient with malposed teeth. My favorite method is to use a rubber dam stamp, or in the simulation lab, have a pre-punched rubber dam that you can place over a new rubber dam to mark the holes you want to use. The large hole on your punch is for molars. Let's call it size number 5. Size number 4 is for premolars. Size 3 is for canines, size 2 is for maxillary incisors, and size 1, the smallest hole, is for mandibular incisors. Dentition size may vary from patient to patient though, so select whichever holes will work best for what you see in the mouth. When punching your holes, make sure to get a clean hole, stretching your dam if you have to around the punch. Remove any small pieces before placing in the mouth. When all your holes are punched, go back to your clamp hole and cut 2 additional holes, creating 3 conjoined vertically aligned holes. This will allow slightly more room for your dam to stretch over the clamp. There are many different clamps to choose, and each has their own purpose. For a more detailed explanation on clamp design, refer to your preclinical instructors. I predominantly use the 12A and 13A clamps, always placing them on a molar. The 12A is for the upper left and lower right. The 13A is for the upper right and lower left. An easy way to remember that is to know that when placing these clamps, the wider side always rests on the buccal of the tooth. Since we're clamping on number 18, I'm going to use the 13A clamp. Ligating a clamp needs to be through both holes. Otherwise, if the clamp breaks in half, only one side is ligated and the other free side could potentially be aspirated or ingested. Start by taking a length of floss and fold it in half so the ends come together. Like you'd thread a needle, pinch the floss and thread it through the lingual hole of the clamp. Pull it through and guide it back through the loop and pull taut. Now take the free end again and wrap it around the bow half a dozen times or so until you get near the other side, where you'll thread it again and tie it off. When ligating your clamp, we start on the lingual and end on the buccal. That way, the floss exits to the side of the mouth so we can ligate it to the frame. There are 2 basic methods of placing the clamp and a dam on your patient, a 1-step method or a 2-step method. I use both in the clinic depending on where I'm working, patient anatomy, and visibility. After placing the clamp and dam, you'll need to carefully manipulate the dam between the embrasures using your fingers and floss. Careful not to rip the dam when doing this, or you may have to start all over. I like starting by ligating the contralateral canine with either floss or a widget. This helps to spread the dam out right from the start. In the simulation lab, you may find it helpful to use some type of lubricant to slip the dam into position. With patients in the clinic, their saliva will suffice. After carefully flossing each embrasure, go back to your clamp tooth and make sure none of the gingiva is exposed. You may have to jimmy the clamp a bit until it fits perfectly. Remember to clamp near the CEJ and not on the gingiva itself. This can cause undue trauma to your patient. The next step is to invert your dam with hand instruments. This is not an optional step and is essential to a high-quality isolation. Without doing this, you could find blood or saliva moving into what you thought was an isolated and dry field. Finally, ligate the clamp with a simple overhand knot or 2. In the event the clamp does break, it won't fly across the room. Here are some final photos of the rubber dam I've completed. Good luck, and let me know if you have any questions.